everyone. This afternoon, we are going to have an inaugural grand round of Redus Center for Digestive Health. We are lucky to have a distinguished speaker, Dr. Ayo Abegunde, be with us today. I am here with Dr. Evaristus Chukwudike as moderators. My name is Dr. Chukwudike. I'm a general laparoscopic surgeon. And Dr. Eva is the gastroenterologist and hepatologist. He's the head of Endoscopy at Redus Center for Digestive Health. He'll be helping us with the Q&A session of this discussion today. I'm going to run a quick resume of our speaker. Dr. Ayo Abegunde is an associate professor and chair of the Division of Gastroenterology and Hepatology at John H. Stroger Jr. Hospital of Cook County in Chicago, Illinois, USA. He earned his medical degree from the College of Medicine, University of Lagos, Nigeria here, and has completed extensive postgraduate training, including residencies in family medicine at the Royal College of General Practitioners in the UK and in internal medicine at John H. Stroger Jr. Hospital of Cook County. He has also completed a fellowship in gastroenterology at the University of Oklahoma. Also had advanced training in tropical medicine and international health at London School of Hygiene and Tropical Medicine. Clinical trial trainings through the Global Clinical Scholars Research Training Program at Harvard Medical School. His clinical and research interests center around medical education, inflammatory bowel disease, colon cancer screening, microscopic colitis, gastrointestinal infections, and gut microbiome. He has served as principal investigator in several multi-center clinical trials and has published so many papers, over 100 in scientific abstracts and manuscripts. He's an active reviewer for multiple journals and is a member of the American Gastroenterology Association Academy of Educators. He's also a fellow of the American College of Physicians, the American College of Gastroenterology, and the American Society for Gastrointestinal Endoscopy. I'm going to hand over to Dr. Ayo now to proceed. Professor Ayo, please.
Good morning, everybody. Thank you for inviting me to this webinar session, the inaugural Grand Round session for the Redus Digestive Health Center. Dr. Ulasi, thank you for the kind words. Dr. Evaristus Chukwudike, I'm also grateful for the invite. So we're going to be talking about inflammatory bowel disease in Africa. Now, this is a big topic, and we'll start first with a couple of disclosures. So I'm a consultant for pharmaceuticals. Everything I will discuss today will not be in any way or form in conflict with my role with pharmaceuticals. The outline of our talk today will define inflammatory bowel disease. We'll talk briefly about the pathophysiology of inflammatory bowel disease for those who are not familiar with the condition. We'll also discuss, compare Crohn's disease and ulcerative colitis, which are two major forms of inflammatory bowel disease. We'll go on to talk about the epidemiology of IBD in Africa for the purpose of this presentation. When I talk about IBD, I'm referring to inflammatory bowel disease. We'll talk about the distribution and scope of published research in IBD in Africa. We'll talk about the genetics, environmental factors, characteristics, and disease phenotypes of IBD in Africa. We'll talk about treatment patterns and challenges in the IBD management in Africa. We'll now look at IBD management as a whole and look at barriers and opportunities for improvement of care. And we'll conclude with a few take-home messages. So inflammatory bowel disease, what is it? Well, it's a chronic immune-mediated disorder of the GI tract that encompasses two major subtypes, Crohn's disease and ulcerative colitis. The condition typically manifests in the second and fourth decade of life and follows a chronic relapsing or remitting course. The pathophysiology is really, the general consensus now is that it's an inappropriate inflammatory response to intestinal microbes in genetically susceptible hosts. So if you look at the cartoon below, you see there are three big sort of factors that need to come into play. The genetic susceptibility, microbial flora of the gut, environmental risk factors. Now, if you look at the schema, dysbiosis is a condition where the balance of the microbiome is disturbed within the intestine, and that leads to an impaired immune response, an outreach of inflammatory mediators. This causes mucosal inflammation. There's tissue damage, breakdown the line of the mucosa, and there's permeation of fluid within the mucosa out, and patients get diarrhea and some of the symptoms that we come to know with inflammatory bowel disease. So this looks at the two major types of inflammatory bowel disease and looks at things that they have in common and things they don't have in common. So if we talk about the anatomic distribution in terms of ulcerative colitis, it's limited to the colon, starts in the rectum and extends proximally, whereby Crohn's disease can affect any part of the gastrointestinal tract from the mouth to the anus, and it's characterized by what we call skip discontinued lesions. Depth of inflammation. Now, with ulcerative colitis, you have mucosa and submucosal inflammation, so the inflammation tends to be superficial, whereas in Crohn's disease, you have deeper levels of inflammation in what we call transmural inflammation, which means all layers of the intestine are involved in this inflammatory process. The pattern of inflammation can also differentiate the two. With ulcerative colitis, you have continuous inflammation and ulcers. In Crohn's, you have discontinuous inflammation. When you look at these patients, examine them on endoscopy, you'd see diffuse continuous inflammation with clear demarcation between inflamed and normal tissue in patients with ulcerative colitis. In those with Crohn's disease, you may find discontinuous or something what we call cobblestone appearance of the line of the mucosa, and you have the ulcers, but it's not continuous. When you look at it under the microscope on histology in ulcerative colitis, you see basal plasmacytosis, which typically means the earliest lesion. And what you're really looking for is chronic inflammatory changes defined by distortion in the architecture of the cells within the colon. In patients with Crohn's disease, you will see non-caseating granulomas, as well as the inflammatory, chronic inflammatory changes that we described in ulcerative colitis. The main complications for ulcerative colitis is bleeding. These patients can also develop very distended colon, something called the toxic megacolon. In Crohn's disease, they get fibrotic strictures, fistulae. These conditions also carry a long-term risk for colon cancer. The clinical symptoms, how do these patients present? Abdominal pain, diarrhea, which is chronic, tends to be greater, ongoing for more than 4 weeks. Typically, patients are presenting with 3 to 6 months of symptoms before they come to the doctor. Rectal bleeding is seen in 90% of ulcerative colitis patients. You may see rectal bleeding in Crohn's disease patients, but not all the time. Both conditions are characterized by symptoms outside the intestine. Some of these symptoms can vary from arthritis to inflammation of the eyes or cholangitis. Something called primary sclerosing cholangitis can be seen both in Crohn's disease and ulcerative colitis. However, primary sclerosing cholangitis is more common in patients with ulcerative colitis. Now, in terms of genetic associations, ulcerative colitis is associated with what you call the interleukin-10 RA variant, while Crohn's disease is associated with what you call the NOD2, the ATGL16L1, which is an autophagy-associated gene. So in a nutshell, those are how you can sort of differentiate both conditions. On presentation, also regarding the depth of inflammation and the complications that can arise from these conditions. This just gives you a schema of what the mucosa may look like when you do an endoscopy. On this part, this is what the normal mucosa will look like. You can see it's smooth, pink, no ulcers. In Crohn's disease, you see something called cobblestoning, like I described earlier on, which is sort of the cardinal feature of Crohn's. You also have intramural, transmural inflammation. And as you can see, it's the whole gastrointestinal tract that's inflamed, mucosa, submucosal, and the deeper structures. And you see something called fat wrapping as well, which you may see in Crohn's disease. In ulcerative colitis, as you can see, the inflammation is more superficial. You may see decrease in the vascular markings. You may see continuous inflammation. You don't see that transmural inflammation that you will see in Crohn's disease, and you don't see the fat wrapping as well. So what do we know about the incidence of IBD in Africa? IBD is increasingly recognized in Africa, and the incidence is rising, although on the whole it's rare compared to what you would find in the West and increasingly now in Asia. The overall incidence, like I said, remains low. The true burden remains uncertain due to diagnostic challenges, limited data, and high rates of infectious diseases mimics in Africa. Studies have indicated a comparable incidence of CD and UC, with some suggestion of predominance of UC in certain regions. In South Africa, for example, the incidence of Crohn's disease and ulcerative colitis is about 3 per 100,000 population, or 5 per 100,000 population, respectively. In Libya, just to put this in context, pediatric onset IBD showed a fourfold increase in incidence from 0.2 to 0.9 per 100,000 population between 2002 and 2006. However, there's a lack of high-quality epidemiological data, particularly in sub-Saharan Africa, and so this limits what we know about IBD in Africa. Now, what do we know about the published research? So this map basically shows you the countries where we have some data regarding the incidence or treatment of IBD in Africa. And as you can see, majority of the studies originate from South Africa, Egypt, Tunisia, and Morocco. There is limited data from Central or West Africa, with Ghana and Nigeria sort of predominating in West Africa. And as you can see, in the whole of Central Africa, there's about a lack of studies. However, most studies are retrospective, hospital-based, and we have so small sample sizes, so there's limited generalizability of the available data. And this is borne out by the fact that there's a lack of population-based registries, a lack of longitudinal outcome studies, and a lack of clinical trials involving African patients. This pie chart looks at where the focus has been regarding IBD research in Africa. And as you can see, most of it has centered around treatment utilization, disease phenotype, a few studies on genetics, extraintestinal complications, very small proportion accounting for surgery, diagnostics, or quality of life. What do we know about the genetic factors associated with IBD in Africa? Genetic studies in IBD in Africa are primarily from North Africa. About 83% of all genetic studies are coming from North Africa. And these studies reveal both similarities and differences compared to the Western populations. The NOD2 COD15 gene mutations were also linked to the CD phenotype in Algerian and South African populations. That's similar to what we'll see in the West. Variants like the CTLA4 and PTPN22 show discordant associations in different African populations. The TPMT and ITPA gene variants were also associated with diverse effects of azathioprine in Egyptian patients. There's a need for more comprehensive genetic research to understand the implications of treatment and management in African populations. And this is because, you know, we really want to understand whether the genetic factors in the West are similar or different from those in Africa, which will help us tailor our research and treatments a little better. So environmental factors for IBD in Africa, these play a significant role, but the impact across various regions has been mixed and varied. Most studies on the environmental factors are from North Africa, accounting for about 43% of all studies. and South Africa, accounting for about 35%. The common risk factors, which are similar to some of the risk factors in the West, urbanization, increasing urbanization has been associated with an increased incidence of IBD. Adoption of westernized diets, highly processed foods, has also been shown to be associated with IBD in Africa. Reduced exposure to helminths, that's the hygiene hypothesis, which says that with reduced microbial stimulation, there's a tendency to increase dysbiosis and inflammatory bowel disease. Chronic antibiotic use has also been shown in being a risk factor for IBD in Africa. And this is because antibiotics not only cure the infection, but they also have collateral damage to the gut microbiome, which also predisposes patients to dysbiosis. Smoking, especially Crohn's disease, has been shown to be an environmental risk factor for development of Crohn's disease in Africa. So how do patients present? We're talking about the characteristics of disease and disease phenotypes. Well, this phenotypic presentation varies across Africa. There have been some distinct patterns observed in Crohn's disease and ulcerative colitis. Non-stricturing and non-penetrating disease is the most common phenotype of CD patients. In ulcerative colitis patients, left-sided colitis seems to be more common, at least from reported studies, with pancolitis noted in about 41% of cases. One study indicated that ileocolonic disease is prevalent in about 41% of Crohn's disease patients. Factors such as perineal fistulas and hypoalbuminemia are associated with disease progression. The hypoalbuminemia CRP ratio greater than 0.6 has been associated with severity in patients with IBD in Africa. So, treatment patterns and challenges in IBD management in Africa. There's a heavy reliance on traditional therapies with limited access to advanced treatments. What do I mean by these traditional therapies? A heavy use of corticosteroids and 5-aminosalicylate acids. Studies indicate there's an infrequent use of azathioprine and 6-mercaptopurine. A study in South Africa showed that 55% of patients had never been treated with azathioprine or 6-mercaptopurine. Adverse events were associated with azathioprine treatment, which include digestive intolerance and hematologic toxicity. Access to biologics is also limited, with only about 3% of patients referred for surgery in some studies. Other challenges to the treatment of IBD in Africa are related to late diagnosis, affordability of care, and competing infectious diseases mimics, which can delay diagnosis and treatment of patients with IBD. When we look specifically at ulcerative colitis, the available studies suggest that it's more prevalent than CD. Aminosalicylate sulfasalazine is widely used. It's because of its low cost and acceptable efficacy in mild to moderate ulcerative colitis. There's limited access to mesalazine formulations, which is another form of the 5-aminosalicylates, which give you a bit more, latitude in terms of prescription and also in terms of safety. Corticosteroids are widely used, and long-time steroid exposure is common in patients with ulcerative colitis in Africa. In Crohn's disease, it's about the same. Aminosalicylates are often used despite limited efficacy. Now, aminosalicylates have reasonable efficacy in ulcerative colitis. However, in Crohn's disease, they're not as effective. However, in Africa, we see that patients are still prescribed these treatments, even though we know they're not as effective for Crohn's disease patients as compared to ulcerative colitis patients. Methotrexate is frequently used due to its affordability. Thiopurines are available in selected countries with variable use. And so biologics, immunomodulators like azathioprine, obviously there are issues regarding the use of this in Africa. This is because monitoring is often limited. So monitoring for side effects is often limited. And this is because there may be issues regarding lab draws and effective screening and results sent in a timely manner. Also, drug supply interruptions may affect the steady flow of these immunomodulators. And hence, like I said in the earlier slide, methotrexate is more widely used due to its reduced cost. Biologics. And this specifically refers to anti-tumor necrosis factor medicines, which have revolutionized the treatment of IBD in the West. There's variable availability, mostly in North Africa, Egypt, Algeria, Tunisia, and Morocco. Although even in those countries, the overall access remains limited. In sub-Saharan Africa, mainly it's found in South Africa. The introduction of biosimilars, which are medications, generics, that are similar to have the chemical characteristics of the anti-tumor necrosis factor agents, but they're at a more affordable price, may help to change this. But the uptake of biologics generally outside South Africa remains minimal. Infection risk considerations. There's a high burden of latent TB and chronic hepatitis in Africa, and therefore screening and prophylaxis is essential before you want to treat patients with IBD with immunomodulators or drugs that can suppress their immune system to prevent reactivation of these chronic debilitating infectious diseases. And this risk often limits the widespread use of biologics because of inability to either rapidly detect these patients or to provide adequate prophylaxis before treatment. Surgical options. Early surgery is viable for isolated celiac ileocecal disease in Crohn's disease. It may reduce the need for long-term immunosuppression. However, access to colorectal surgery varies. Surgery remains an important alternative where medical therapy is limited, particularly for patients with ulcerative colitis. So looking at IBD management in Africa as a whole, if we think about the barriers, although there's a rising recognition of IBD, multiple systemic challenges hinder access to healthcare. System-level barriers include supply chain instability, regulatory challenges, widespread counterfeit medications, cost. And if it's the key challenges, if you look at it from a structural healthcare system perspective, there's a low awareness of IBD among clinicians, patients, and policymakers. There's limited access to endoscopy and pathology services, which are critical for diagnosing this condition. And there's limited access to biologic therapies, which have revolutionized care. Not to talk of advanced therapies, because therapeutic options in IBD is a rapidly expanding field with newer therapies coming out by the day, which have actually revolutionized the care of this patient. So really getting access to efficacious medicines is key. So what are the opportunities? We've mentioned that delays in diagnosis and treatment. This is typically due to low suspicion of IBD and initial misdiagnosis, competing diagnoses such as infections, which may complicate the management of IBD. So there are opportunities to improve this via education, widespread advocacy, and increasing knowledge of IBD amongst clinicians, the general public, policymakers, and the government. This also feeds into the limited availability of diagnostic centers. There are opportunities for improvement of an increase in the availability of those diagnostic centers by partnerships with international organizations, private sector, the non-governmental sector, and government. Significant treatment gaps, post-diagnosis, and limited access to essential therapies. This is critical because even when you make the diagnosis, there's no access to treatment. So there are opportunities to improve that through public-private partnerships, partnering with pharmaceutical industry and with international non-governmental organizations to increase the access to these essential therapies. The high cost of care negatively impacts patient outcomes. There are opportunities also to reduce the cost of care by the provision of biosimilars, by the provision of medication assistance programs through pharmaceutical industries, which may also be one way to fund some of this care in Africa. Then there's a significant disparity in treatment and regarding the standards of treatment between Africa and the Western world. How do we close that gap? That can be done also by partnership and also trying to get more of the newer therapies, at least biosimilars, if we can't get the advanced therapies here. Innovative context-specific delivery models will be needed to address these challenges. So how do we go about doing that? We have to focus on practical, achievable solutions. 1, increase awareness and advocacy. 2, capacity building involving the training and workforce development, expansion of endoscopy services, and partnerships like I mentioned earlier on. In order to increase awareness and advocacy, there are already some organizations doing that. In Nigeria, you have the Society of Gastroenterology and Hepatology in Nigeria with the acronym SOGAN. Other countries within Africa, under the guidance and partnership with the World Gastroenterology Organization, have country-specific societies which are also trying to improve training, increase awareness, and provide sustained advocacy. The Gastroenterology and Hepatology Association of Sub-Saharan Africa. This is a network of 15 sub-Saharan African countries. There's a weekly virtual education in gastroenterology and IBD. This weekly virtual education sessions are supported by the ECHO project. This is a partnership with the University of New Mexico Health Sciences Center. And this aims to sort of continue to provide CME guide clinicians on the management of IBD in Africa. The IBD Africa, it's an NGO based in South Africa. Its main focus is patient advocacy and education with a vision to improving the awareness and access to information about IBD in sub-Saharan Africa. More regarding workforce development, there's an urgent need for structured IBD training, given that there are limited gastroenterology fellowship programs, particularly in sub-Saharan Africa. Key initiatives will be leveraging international training partnerships from the ACG, the American Society of Gastroenterology, Endoscopy, the World Gastroenterology Organization, expansion of local GI fellowship programs within countries, public-private partnerships, university affiliations, development of regional centers of excellence. These ways are ways leveraging telemedicine. These are ways in which we can reinforce training and develop sustainable local clinical expertise, which will be able to guide the care of patients with IBD. More regarding training and workforce development, the World Gastroenterology Organization has centers of excellence established in these African countries. They organize train the trainers workshops, which is a way they try to increase the cadre of gastroenterology professionals in these countries in sub-Saharan Africa. And the key will be to leverage those centers, partner with those centers, provide funding for those centers to be able to carry out their responsibilities in an effective and efficient way. So how do we go about expanding endoscopy services? This is going to require innovative solutions. 1, community awareness and screening programs, use of non-invasive tests such as the fecal immunochemical test or stool H. pylori to triage for endoscopy, deployment of mobile endoscopy units, training of non-physician clinicians like general practitioners, nurse practitioners, teleendoscopy and remote mentoring, meaning that experts can have a further reach via teleendoscopy, task-specific regional hubs, so creating regional hubs where you do specific tasks such as upper endoscopy and colonoscopy only. In some patients regions, they may do a combination of advanced endoscopy or we do a combination of non-invasive testing for gastroenterologic conditions such as CT enterography, video capsule endoscopy, low-cost innovative technology, the use of disposable, reusable, single-use endoscopes, capsule endoscopy for remote diagnosis, or deployment of AI-assisted detection support by non-specialists. The focus should be on solutions with proven effectiveness in urban, rural, and remote settings. And this will require partnerships to pilot some of these programs, and then going on to scale up those ones that are found to be effective and cost-effective as well. Regarding partnerships, we're talking about governmental and non-governmental sectors, private hospitals, universities, pharmaceutical industries, local and international GI societies. The potential benefits are: one, you can offset the high initial cost of equipment. You can increase access to screening, diagnostic services, and medications. You could establish regional hubs for equipment maintenance and supply chain management. You'll be also rotate train teams that can manage multiple mobile endoscopy units efficiently. Continuous training, certification, and medical education. So in conclusion, the IBD care gaps in Africa are significant, particularly in sub-Saharan Africa, but the care gaps are addressable. Multiple interventions are needed in policy, education, access, and research. The priorities should be education and advocacy, training healthcare workers, expanding endoscopy services, improving access to effective medicines, research on the epidemiology, genetics, natural history, and treatment of IBD, through the establishment of IBD registries and prospective studies to further understand and inform policy on IBD management in Africa. This requires collaboration for sustainable progress. Thank you for listening. I'll take questions now.
Thank you, Dr. Ayo. That was an interesting presentation I've made. IBD continues to be a challenging area in Africa and then in Nigeria, where those of us are practicing. Generally, we have people presenting very late, developing serious complications, which we all know that before the patient comes to see the specialist, the patient would have gone to many places. Even the high index of suspicion is not there. So generally, we have a very low index of suspicion for inflammatory bowel disease. Part of it making it difficult for patient to present early to the specialist. You have raised important areas of concern about why you are presenting. So we want to tell our participants, all the people that have joined this presentation, please begin to send your questions in areas of concerns so that we can address it using this presentation. I'm going to start with you with asking the questions from my end while we wait for our participants to answer questions.
Okay.
We have even the challenge of diagnosis. If the patient presents with us, what are the common differential diagnoses that one will be looking at when you are suspecting inflammatory bowel disease? There are many people. We have a diverse group of people that have joined this presentation. So we want to find out what are the differential diagnoses that one should be looking at when one has when you are suspecting inflammatory bowel disease. If it is not inflammatory bowel disease, what could it be? Over to you.
Okay, thank you for that question. The cardinal presentation in terms of symptoms: abdominal pain, chronic diarrhea, rectal bleeding. Those have a broad differential diagnosis. In Africa, you always want to think about infectious forms of colitis as one of the differential diagnoses. Now, in that infectious cause of colitis, there are a number of things that can present similar to IBD. Amoebic colitis, strongyloides infection, TB, intestinal TB, also other bacterial colitis, viral colitis like CMV. Other things that could present with diarrhea or change in bowel habits, with blood, colon cancer. So that's another differential. Patients may have more rarely, I'd say, chronic diarrhea, microscopic colitis. They may also present with other causes of rectal bleeding, such as hemorrhoids, which is often a diagnosis that really, in a patient that has abdominal pain, chronic diarrhea, and rectal bleeding, that shouldn't be your first differential diagnosis. So I'd say in patients with chronic diarrhea, abdominal pain, and rectal bleeding, you always want to think about, in Africa, infectious causes first, inflammatory bowel disease, colon cancer, very rarely, diverticular bleeding, but really diverticular bleeding will not present with chronic diarrhea. It presents just with rectal bleeding. So those are the sort of common things you want to think about in patients presenting with chronic abdominal pain, chronic diarrhea, rectal bleeding. Now, the infectious causes can be ruled out by tests, stool tests, but in a patient with rectal bleeding, chronic diarrhea, and abdominal pain, you really need to do further testing. So even if some of the stool testings, all the stool tests come back negative, you still don't have an answer for that. So you need further testing. Clearly, if you can't get an endoscopy is warranted, and on endoscopy, you can do a number of things. One, the endoscopy, you can visualize the mucosa. Two, you can see if there are any ulcers. Three, you can take biopsies. Taking biopsies is critical to making the diagnosis of inflammatory bowel disease because there's characteristic finding on the biopsy sample. You would see chronic inflammatory changes. Now, on histology, on the histology of colonic biopsies, those chronic installation changes are critical. This is where your pathologist comes in. A pathologist that's used to making a diagnosis and used to seeing IBD can differentiate IBD from other forms of colitis. And the IBD diagnosis is clearly you want to see lymphoplasmacytic inflammation, chronic architectural distortion. If it's Crohn's, you may see granulomas, but that chronic change is what you want to see. The crypts are distorted, not just inflamed, and those are things that will clue you to the diagnosis of IBD.
Thank you. We have a comment and a question from one of the participants. He said, excellent presentation. Will the panel comment on the role of nutritional therapy, particularly exclusive enteral nutrition as primary or adjunct treatment in pediatric Crohn's? It is showing promising remission rates with mucosal healing in children. Not sure how effective in adults Crohn's. So did you get the question?
Yes, I did. So that's exclusive enteral nutrition or parenteral. Parenteral or enteral? Enteral nutrition, yeah, okay. Now, regarding IBD, really, you want to feed the gut as much as possible. So even in the pediatric population, those patients that are placed on the exclusive enteral nutrition, there has been some resolution, but if you compare, it's not generalizable in terms of the data supporting that. You want to feed the patient as much as possible because one, you're trying to reduce that immunogenicity of the intestinal microbiome. The theory behind that is that with that exclusive enteral nutrition, if it's what we call straight, then you can see that those pediatric patients may get better. But in adults, it's not a big treatment paradigm because we have so much more effective therapies available now. We have advanced therapies, we have biologics, which target the pathways of pathologic pathways in Crohn's disease. So those patients, the first of the advanced therapies were the, anti-TNFs, which target tumor necrosis factor, which we know is a putative factor that causes inflammatory bowel disease or causes flares in inflammatory bowel disease. We now have the anti-integrins, which work via another pathway, which reduce inflammation in IBD. We also have the interleukin-23 inhibitors, also targeting another pathway in IBD, as well as the JAK inhibitors, targeting another pathway in IBD. So advanced therapies have moved exponentially now, and we have so many options that subjecting adults or even in the pediatric population to exclusive enteral nutrition as a primary source of achieving remission in IBD is not popular.
Thank you. So as a follow-up to the first question, would you recommend use of oral iron therapy in the management of IBD patients with anemia?
Yes, it all depends on how significant the anemia is, right? So iron therapy can be used in patients with inflammatory bowel disease, especially because anemia and fatigue are a common condition these patients present with. As you know, the evidence has moved beyond here where, you can supplement them with the lowest dose possible. Now, intravenous iron may also be used in those patients where you feel that there's an issue with absorbing iron orally, or if they have terminal ileal disease or they have small bowel Crohn's disease. The option to use IV iron is there. But yes, you can give patients oral iron, depending on how severe their anemia is and how much iron deficit they have.
Thank you. Another question from one of the participants here. Patient would want you to talk on the role of antibiotics in the management of IBD.
Okay, yeah, that's a very important topic. Antibiotics have shown some efficacy in IBD. The earlier studies from the 80s and 90s showed that antibiotics could achieve remission in some IBD patients. We also use antibiotics in cases of IBD patients that have had ileoanal pouch anastomosis, and if they have something called pouchitis, that's inflammation of that ileoanal pouch. But in terms of generalizability, is it one of the approved treatments now? for IBD, I'd say only in very, very selective cases. For example, if you had limited resection in a patient with Crohn's post-op, you can use metronidazole. There's been some studies done by Dr. Paul Rutgerts from the early 90s that showed that metronidazole was effective in patients preventing recurrence post-surgery in select IBD patients.
Thank you. So there's a very big some areas that look controversial sometimes we want you to address. We have a patient with severe IBD where people are looking at now, should they start with top-down treatment approach or bottom-up treatment approach? Where do I align in that treatment? Or are there reasons why one should start top-down and bottom-up approach?
So the principle of step-up or step-down approach, right? Historically, we have advocated a step-up approach, meaning that you start with the 5-aminosalicylates. If the patient is not doing better, then you increase the care, add an immunomodulator, and then maybe a TNF. But extensive studies have showed now that that may increase the patient's risk of complications. So hence, and obviously with the advent of the new effective therapies, the thinking now is to treat patients aggressively, especially those with moderate to severe, patients that present with moderate to severe inflammatory bowel disease. You want to control that inflammation early to prevent complications. So there are three parts of your treatment. One, you want to get clinical response, clinical remission. That is the patient, obviously, if they had a lot of blood, 10 stools a day, you want that to reduce to no blood, and from 10 stools a day to like 2 or 3 stools a day. That's your clinical response. Remission means it's sustained, meaning that they get back to their normal. And then you want to also check for biologic response, right? Which is your objective measure. So clinical, the person tells you you're feeling better. You also may note that the patient is feeling better from resolution of symptoms, but then CRP and stool calprotectin. So these are biomarkers that are not readily available in Africa. The CRP you can get, but calprotectin is not widely available. And so you want that biologic correlate before you now get mucosal remission, and that you can only check by colonoscopy. So there are a lot of prospective studies that are showing now that top-down approach prevents complications, improves quality of life, makes the patients feel better. And as you know, with the newer treatments, we now have, not only do you have self-injectable medications whereby the patient doesn't have to sit for an infusion, you also have oral treatments, which means the patient can take 1 pill a day and they achieve remission, and they continue on maintenance with oral remission. So that's why there's been a shift in sort of recommendations for the management of IBD, that those patients with moderately to severe disease, you want to catch them early, you want to get them in remission early, and you want to maintain remission for a longer time. So hence, the switch. In Africa, we may not be able to do that just because we don't have the availability of those treatments. But in those places where they can achieve, they have access to biologics or biosimilar, they too may be able to approach the care of their moderately severe patients with that sort of top-down approach.
Thank you. We have an internal medicine PGY2 resident from the University of Texas who joined this discussion. He's asking, he said it appears that there are limited data regarding IBD care, especially in Nigeria. Just wondering if we have cheaper ways of screening that would at least get us close to the diagnosis and understanding that colonoscopy is not cheap and treatment is also expensive. We want you to make a statement on that.
Thank you for that question. With IBD, the key to diagnosis is endoscopy and biopsy. Now, non-invasive markers of bowel inflammation, you can use them as correlates for response to treatment. Like I mentioned, the stool calprotectins. Now, stool calprotectin is a marker of intestinal inflammation, but not only IBD patients have an elevated stool calprotectin. So using stool calprotectin alone and symptoms wouldn't give you the diagnosis. Having said that, even histology, you need a histologist, a pathologist that really knows about IBD, because infectious colitis or any other form of colitis, such as drug-induced colitis, they can have some changes on histology that may mimic IBD. So things like cryptitis, crypt abscesses, you may find that in infectious colitis, you may find that in drug-induced colitis, you may find that in acute self-limiting colitis. But if there's no chronic architectural distortion or chronic architectural changes, then that is not IBD. So it's not as clear-cut as, oh, we can use a non-invasive marker, because even histology, you need to have specialist know-how to be able to interpret that histology in context with the patient's symptoms. And so I know that colonoscopy is now widely available in Nigeria. I know that gastrointestinal pathologists are now widely available in Nigeria. And that's why during this talk, I focused on the barriers and how we can address them. And this talk is one just to set the stage for what we can do to increase the number of gastroenterologists, increase the number of pathologists that are aware. Awareness first is the first level. How do we increase the awareness amongst healthcare providers, amongst general practitioners, amongst nurse practitioners? Who are the people who will see patients first, right? How do we increase the awareness that there's IBD in Nigeria, there's IBD in Africa, these are the signs, and this is what you should suspect. And if you see this kind of presentation, it's noteworthy to refer those patients to the centers such as Redus, where this high-quality colonoscopy can be done, biopsies can be done, and pathology can be read to make the diagnosis. So critically, the landscape of healthcare needs to evolve in order to take care of these patients. And the more patients we diagnose, the more we get registries, the more we're able to seek partnerships to try and care for some of these patients with IBD.
Thank you. We are running short of time. We can have less than 10 minutes to go. But there are many questions there. Just to ask some, then we may be responding to others after this presentation. This is one question. We have a young Nigerian patient that we first saw for primary sclerosing cholangitis. Subsequent screening, colonoscopy revealed ulcerative colitis, even though he was asymptomatic. How should we be thinking about cancer screening, looking at colorectal cancer, cholangiocarcinoma for him in our setting, modality, and timing?
So that patient, like like I said earlier on, IBD has a relapsing and remitting course, right? The diagnosis of PSC already means that that patient has had ulcerative colitis for some time. And at that point, he needs a colonoscopy, regardless of his age, because when you diagnose PSC in UC, their risk for colon cancer increases exponentially. And patients with PSC and UC, or PSC and Crohn's disease, will require a yearly colonoscopy to screen for colon cancer. PSC patients are also at risk for cholangiocarcinoma. And in a setting like Africa and Nigeria, whereby, surveillance may be difficult, but the way you want to survey these patients for cholangio is a non-invasive test like an MRCP. If you do find dominant stricturing or concerning lesions, then you want to follow that up with something invasive like ERCP to take biopsies, or spyglass cholangioscopy to take biopsies. Now, those are really advanced procedures that are not readily available in Nigeria. And we have to start to think about these sorts of diagnostic modalities and how we can make them available. Now, they don't have to be available in all institutions, but if you looked at my my presentation, I spoke about regional hubs or centers of excellence, whereby, okay, in this particular place, let's invest and let's make sure they have ERCP or capability to do advanced procedures when they come or when they arise. But in terms of screening for colon cancer, you have non-invasive options, right? Like the fecal immunochemical test or the stool fecal alcohol test, blood test. Now, these are not replacements for colonoscopy. Those tests are options in patients to have average risk of colon cancer. But in patients with IBD, they carry a higher risk of colon cancer just because of the chronic inflammation. And so those non-invasive tests are not really options for patients with inflammatory bowel disease. They need colonoscopies. The other thing is that in patients with inflammatory bowel disease, they can get cancer without forming polyps, right? So they can have flat lesions that are cancerous. And that's why colonoscopy is actually crucial, and actually high quality colonoscopy. The guidance is that you use something called chromoendoscopy, which is a dye, or you use natural band imaging to provide a contrast in the mucosa in order to detect this flat pre-malignant lesions in IBD patients. So it really it calls for a multi-pronged approach, increased awareness by healthcare providers such as yourselves, ourselves, everyone on this talk, and a sustained advocacy and support and partnerships with many organizations, universities, the governments, non-governmental, and the international partners as well.
Thank you. So we will have one more question.
Okay, sure.
I'll ask the one that many people have asked. There are multiple questions asked by different persons in the same thing.
Okay.
The question is, at what point should a surgical consultation be sought for a patient with acute severe ulcerative colitis? I've seen many people also that answer questions.
Okay, so for acute severe ulcerative colitis in patients with toxic megacolon that's not responded to 3 days of immunomodulators, 2 days of corticosteroids or advanced therapies. So in those patients, they're at risk of perforation. You would want to monitor them in hospital, and you would monitor the CRP. And like I said, those are correlates. The CRP response on day 3, if that's not down, you want to consider early surgical consultation, because then in that case, they're at a risk of perforation, and then you're doing the surgery as an emergency as opposed to an urgent planned procedure. In Crohn's disease, there are more indications for surgery. Sometimes if these patients have fistulae, right? They have perianal fistulae. They could have vesico rectal fistulae. They could have recto-vaginal fistulae. They could have intra-abdominal fistulae. So these patients, they may have strictures that cannot be bypassed by endoscopy. They may present with obstructive symptoms, small bowel obstruction, colonic obstruction. So in those kind of conditions, those patients especially Crohn's disease patients, may require early surgery, bowel resection. Crohn's disease patients are also at risk of what we call small bowel syndrome, short bowel syndrome, short gut syndrome. And that's because if they have refractory disease that is unresponsive to many medications and they've had multiple resections, they now have a condition where they don't have enough intestine to absorb their nutrients, and they may need parenteral nutrition as a destination.
Thank you. We apologize to our participants because we have so many questions here. But time failed us to take all of them during this meeting. But we'll be answering the questions even after this the discussion. Dr. I want to hand over to you to make your final comments before we wrap up this discussion.
So thank you very much, Dr. Chukwudike. Thank you, Dr. Wilasi, and thank you to my colleagues on the call who listened to this webinar. IBD is rising in Africa and in Nigeria. Historically, it's probably been there, but we weren't able to detect it because we didn't have the tools. Now we have the tools, although in limited facilities. The charge really is to increase ability to diagnose, to detect, and the awareness. And I think starting with awareness is the most important thing. Getting that awareness to the hospitals, to the public, to schools, universities, students, secondary school, universities is one way to get it out there. And then after that, it is about building that infrastructure to be able to diagnose the condition. This is where partnerships with healthcare, societal organizations, looking for innovative, cost-effective solutions to be able to deliver this care to those patients in the community that have IBD. And the other thing is that it does run in families, so it's also important that patients who have been diagnosed, they let their family members know, and they're all made aware of this condition in Nigeria and in Africa. Thank you.
Thank you so much. At this time, I'll be handing over to Dr. Olas, who is the Chief of Surgery. He's both general surgeon and endoscopy surgeon in our facility, Redus Center for Digestive, to conclude this wonderful session of webinar. Over to you, Dr. Olas.
Thank you so much, Professor Ayo. Thank you, Dr. We are really grateful to have had what I should call a master class, quite insightful, quite educating, and very interesting to follow. Thank you so much for sharing your wealth of knowledge on this topic. And I mean, like Oliver Twist, will always come around to seek for more information and, joining us to discuss more on this in the future. Our Medical Director, Dr. Kenneth Chudong, is on the call. Ken, I don't know if you want to chip in a word or two before we can wrap up.
I just want to express appreciation to Dr. Ayo for taking the time to give us this wonderful talk, and to everyone that has made out the time to join us as well. This is the first of our series, and we're going to continue to have lectures like this to just help us all stay abreast of the latest trends in management and just to help us provide better care for our patients. So thank you all for joining, and we'll send out notifications for future grand rounds as they come up.
Thank you, Kenneth. Thank you, everyone. Thank you, Professor Ayo. And on this note, we draw the curtain on today's webinar, and we'll keep in touch as we prepare to have more of this in the future. Thank you so much, everyone.
Bye.
Thank you. Okay.